Next up, we have our dermatology training program section. Our first speaker, I'm delighted to introduce, is Dr. Jean Bosco. Selfishly, he is my mentee in cohort 2 of the GLODERM mentorship program. Now, Dr. Bosco is currently in the air on his way from Rwanda. He was supposed to be here in person and unfortunately had a small travel glitch, which all of us in global health know is just part of the course. So please, he will arrive tonight. So if you see Dr. Jean Bosco, please greet him, please say hello. He is part of our very well-loved GLODERM family. He's a dermatologist in Rwanda, and he is currently the only dermatologist working in the northern and northwestern areas of Rwanda, which is an area that covers several million people. There are not very many dermatologists in Rwanda, but they are most of them in Kigali. So he's actually working in a more rural area as well as in Kigali. And he runs dermatology training for the medical school at University of Global Health Equity in Butaro, Rwanda, where he's developed a curriculum, and his particular area of interest is also in teledermatology. So he's going to be speaking to us today about expanding dermatologic care in Rwanda. So he managed to, as he did not make his flight, he managed to record very quickly and very last minute. So we thank Dr. Bosco for his quick thinking on his feet. And I think we have it over there. So fantastic.
Hello everyone, I'm Dr. Ndagijimana Jean Bosco. I'm a dermatologist from Rwanda, and here I'm going to talk about the experiences in initiating dermatological care in rural Rwanda, a dual mission focusing on medical education and patient care. And I'm thankful for GLODERM and the International League of Dermatology Society and my mentor, Dr. Esther Freeman. This project consisted of medical education and patient care for patients were in underserved populations, underserved area of North Province of Rwanda, and this picture is the Butaro Hospital where our clinic of dermatology were. North Province of Rwanda count 2.7 million people. That's where Butaro Hospital is located in the red here, and the pink is North Province, and this one is in Western Province that close to it with the 2.5 million people. All two provinces didn't have access to dermatologists until we started this program. And in general, Rwanda counts 14 million people and 12 dermatologists, and people could travel up to 6 hours to Kigali here to be seen by dermatologists, where they can even wait up to 6 months to be seen by dermatologists. And it was recently found that around 30% of OPD outpatient consultation are related to skin disease. This is Butaro University of Global Health and Equity where I work, and that is located in the Burera district. And the curriculum, team, facilities, and implementation. So this project was initiated into 3 steps. First, the curriculum design, second, putting up team and funds, and then the curriculum implementation. And the curriculum was designed to include both theoretical and clinical teaching. Theoretical teaching included the major parts of dermatological diseases, such as viral disease, eczematous disease, papillosquamous disease, but also we discussed about the structure of skin, skin examination, knowledge about morphology of skin lesions, and so on. And the outpatient students were taught in outpatient and patient care, and we case discussions. So many teaching methods were used to deliver the curriculum. And the clinic was set in the process, and from June to 2022 to March 2023, we developed the dermatological curriculum, and from October we secured the American Academy of Dermatology grant. And in September, we initiated the talks, September 2022, talks between the University of Global Health and Equity and the Butaro Hospital administration, which approved our demand to initiate the dermatology unity. That is the first in the North Province and the Western Province. And then we initiated the monthly community outreach at this hospital from January 2023 to April to get the best number of patients to use in the teaching. So our target was to have 25, at least 25 patients per each month of visit. From May to July, that's when we taught the students at this clinic. And in July to September, we were having we resumed the monthly clinic visit, but we found out that the number of patients were overwhelming, and then we had to apply for Damlink grant that was secured, then that supported additional visit each month, and now the outreach is twice a month. Until now, we are waiting for May, July for next cohort of our medical students. And our partners include the American Academy of Dermatology, University of Global Health and Equity, Butaro Hospital, and Ministry of Health of Rwanda, and International League of Dermatology Society through DAMLink grant, which we are thankful for. And as a team, we are very thankful to Dr. Natali here, the chair of clinical division at the University of Global Health and Equity, who supported our program hugely. And this is also we had the nurses at the hospital who facilitated patient registration and the directing patients to our clinic. And the hospital gave us the one clinic room that were equipped with a computer and the open MRIs and internet that we used in the patient registration, keeping the patient data. And then we had the simulation classrooms where we taught the students, and also simulation lab where we used it to teach procedures. And then at this clinic, what we realized that there was a very diverse skin conditions. Initially, all the data in Rwanda in the 70s showed that skin infections were predominant, but by now that trend has changed. So we needed to update our data. Like this one, this is a child that had generalized the lesions, like identified the lesions of atopic dermatitis at 6 years, who was refused to start the school, and through our support, we wrote a letter to the school along with the medical students to the director of the school, and the student was admitted, and now the student is under our follow-up. And this is already a 50 something years that was having this condition of atopic dermatitis for more than 20 years without control. And this is a patient that we saw in the hospitalization that was scheduled for skin biopsy. But when we reached there, we heard the biopsy, and we treated this patient successfully for stasis dermatitis that was impetiginized. And this is a patient who was hopeless, who traveled several kilometers to reach our clinic for generalized psoriasis. And this is a patient who didn't have relief by primary care providers. She was having lesions under breast, as skin, and also in the palms that limited her functioning, and it was found to be pityriasis rubra pilaris. And this is a child with ichthyosis, generalized vitiligo, and the epidermal nevus. And this is a patient who was also having folliculitis decalvans, patient who came crying really, which was very, very disturbing, emotional, because of this condition that was very, very stigmatizing to her. It was a discoid lupus erythematosus, and this is a patient that we saw with a K-lion, and this is 1 month that was after starting increase of fervin. And regarding medical education, so as I said, the dermatology curriculum was so diverse, so that we capture all components of dermatology, common skin diseases. This hospital, University of Global Health and Equity, and the student doing a biopsy. So these students, our first cohort consisted of 30 students that were divided into 3 groups. So they were rotating between dermatology, dentistry, and the radiology. And at the end, our program, the average was 83.12% score that was similar to other departments where they located. We face some challenges like lack of equipment, shortage of dermatology medication, since so many medications are not on the list of essential medications, so they cannot be procured to hospital pharmacies. So we had sometimes to send patients to private pharmacies, and even economic constraints of patients because of the high cost of travel to the hospital because of bad loads. And as a future project prospects, we want to initiate a dermatology program to overcome geographical barriers, and we are conducting regional continuous medical education at the referral hospital in the region, and also to initiate monthly continuous medical education for healthcare providers under UGH through webinars that will be for 1 year. Then each webinar will be once a month, starting from this March. And we are very thankful for our collaborators, University of Global Health, American Academy of Dermatology, and the International League of Dermatology. Of course, GLODERM also for their mentorship. And this project has had the impact whether to patient level, to community level, and also the healthcare system in the world. And even this project is meant that the general practitioners at this hospital, and as this is a patient that was sent to me via teledermatology, and this is 1 week after treatment that was initiated through teledermatology. So I have a teledermatology group that is based on WhatsApp, where we have 220 participants, including GPs, nurses, medical students, and nursing students, where they send cases, and those which we can treat, I give directions to treat the patients, or even to triage who can be transferred. Recent even this is a program that can be initiated in different parts of Africa or across the globe in resource poor settings, because it helps to increase access to care. But it can be complemented by teledermatology, but in our case, it was very difficult to initiate teledermatology because of financial and even policy challenges. But also we need to see if the patients will, even when you put this project in the community, will even patients be able to utilize this? If they can, then we need to think another strategy to improve access to care. So finally, I'm thankful for International League of Dermatology Society and GLODERM, American Academy of Dermatology, University of Global Health and Equity, and the Butaro Hospital for their support in initiating this project. Thank you, Murakoze.